My journey in endoscopic spine surgery started actually in 2016 and 17 when I tried to think about it, and you cannot believe that whenever I heard at that time about endoscopic spine surgery, I thought that it's a matter of myth. Till I met Professor Luke in 2016 in Global Spine Congress. He invited me to come to Korea, and I did in 2017 at that time. I spent there for 1 month. They did about more than 100 cases in 1 month, all of them endoscopic spine surgery, except one multiple, let's say a huge spine tumor, they open it. Otherwise, every cases with endoscopic spine surgery. When I returned back, I start to think about it, and then I met with at that time that we don't have only one company available. They deal with the surgeon through their local distributor in bureaucratic way that I couldn't convince them to start till I reached it was in NASA, I think, in Chicago. I start to negotiate, and I bought the full set even before the distributor of the Maxmore started in Iraq, which is I think that's, from my perspective in Iraq, this is the only way to start the new technique. And when I brought the sets and I started to do the surgery even before my first cadaver courses, because I got some let's say experience and knowledge when I was in Korea, although they shifted toward the UBE rather than uniportal. So in my first 2 cases, I thought that it's uneasy to start it, but what I faced actually, that's I have a friend of mine, he advised me to use the methyl blue, as Professor Hora said, in the transforaminal, because it will be uneasy to identify the disc. And unfortunately, the methyl blue that's available in that hospital was unsterile. And in the first 2 cases that I did, I developed an infection. This was my, let's say, nightmare. And directly I contacted Yap at that time, looking for any mentor or let's say a clarification. And even I think that's Professor Hora advised me at that time. And then I stopped to do the endoscopic spine for more than 8 months, because the 2 cases that I did, I revised them, one through the tubular and the second was fusion surgery. Then after that, I started to do UBE some cases till I attained the first cadaver course. It was 2 years ago, and then after that, I started to do uniportal and biportal regularly in the last two years. Let's say till now I did about, let's say, 500 to 600 cases because I'm only doing it in a private. So I keep, let's say, to do it in private for 2 reasons, because the government hospital, they don't have this infrastructure and they are not willing to invest with the new technology. And the second point, that I bought from my pocket, so I have to make a return of investment in this product. From that time till now, I tried to make my way toward the endoscopic spine easier instead of jumping rather than going from down. So I choose this presentation actually from a previous post that I put it in the LinkedIn, and they got lots of impression, more than 12,000, about 10 conflict to start the UBE technique. And today I put 10 most common questions that's in the mind of anyone who want to start the endoscopic spine surgery, and I want to make an answer from my perspective at least. So the first of thing, that's why endoscopic spine surgery, many guys who is doing, let's say, open or microscopic surgery, they start to ask themselves and ask us. That's why we want to do endoscopic spine surgery. And I think that's this paragraph which showed that in the last few years, how many papers they are talking about endoscopic spine surgery. And this is still to 2020, and I think that's in the last even 3 years, many paper. And the endoscopic spine surgery, when started by Antonian and their groups, it was dealing with a simple disc, but right now, like a Professor Lim do, that he can do the endoscopic spine surgery from C1, C2 till sacrum. And he mentioned one sentences that I like it. That he said that in Korea we don't have, let's say we have two types of spine surgery, either endoscopic spine surgery or deformity surgeon. So that means every pathology can be dealt with endoscopic spine surgery except the deformity. And yesterday late night I discovered this paper, which is matching the first question, that they conclude that doing the endoscopic spine surgery provide dealing with various pathology, not only the disc, and also it is an efficient and safe technique that's comparison or even better than other MIS or open technique. And from my perspective, that the endoscopic spine surgery is an ideal solution for most of the struggling point. As you see in this MRI, I don't think that there is an optimum technique to deal with this foraminal stenosis except the transforaminal or other endoscopic technique. If you want to tackle it by open technique, you have to remove the facet, and if you want to tackle it by tubular through Wilson approach, also it will be not uneasy. And we all know that endoscopic carry less soft tissue damage, and also, you know, it's an important, at least for me, I have to have every year or every time to time a new technique in order to convince myself and also to think outside of the box. Because if I'm working, let's say open technique, if I'm doing open technique, so how can I compete with my seniors to do, let's say, and attract more patients toward the private technique? So you have to have a new technology, new innovation in order to proceed your way. And also, it's important for me because I came from microscopic surgery, and I spent, let's say, less than 15 to 20 minutes to do, let's say, tubular. And you cannot imagine that when you do much more cases and you will shift yourself toward the automation, which is carry high risk of complication. Because one study they did that the 5 years experienced surgeon, they have less complication with compared with the 20 years expert surgeon. If you still do one technique more and more, later on you will develop an automation and you will face more problem. These are the answer of my first question. And second, that's how can we overcome the learning curve? We all agree that one of the big obstacles that's prevent or make any surgeon who want to invest or started the endoscopic spine surgery, that's how can I overcome the steep learning curve and how can I pass this struggling point? As I mentioned, when I was doing the tubular surgery with 20 minutes, so and then I shifted toward endoscopic spine surgery in my initial cases up to 2 hours, it will be not uneasy. But from my perspective, I think that's the first step. That we have tons of online media, videos, demonstration, and also tons of reference, including paper, how I do it, surgical technique, books also, and then cadaver courses like what we are here right now. And the third important steps, which is what I call it a backup surgeon. I trained till now, in the last year, 2 surgeons to do the endoscopic spine surgery in my center, even they didn't attend 1 cadaver courses. So as a backup surgeon, because when I started to do the surgery, in my first 5 cases, I shifted to tubular because I couldn't, let's say, treat the intraoperative struggle that I faced at that time, which was the bleeding. So I put these 12 steps to overcome the learning curve, and I share it in the chapter of this book, which is, I think it's a critical step toward getting your expertise in any field, not only the UBE or the endoscopic spine surgery. So another important point that we have to identify and check that what do you mean by overcoming the learning curve. And there are many factors that determine these steps. It's not a matter of doing 20 case, 40 case, 30 case or other. It's depend on what do you mean by it. Is it do you mean by to do less complication, less time, automation, efficiency or other? And also many factors that determine these steps. It's depend on from where you are. Are you junior surgeon or you are expert tubular surgeon? Because if you are expert tubular surgeon, it will take less time for you to learn the interlaminar. If you came from, let's say, transforaminal injections, so you will have less time to learn the transforaminal approach. But if you came from, let's say, open technique, so it will require more time. Another point that if you are ortho or a neurosurgeon, although, you know, many, if I'm talking about the triangulation in the UBE, the inventor of the UBE was, let's say, a neurosurgeon. But if we are orthopedic, we are more familiar with the triangulation where it's come with the UBE. But again, it's depend on the experience. And also, where you are working. If I'm working, let's say, in one of the advanced center, let's say in Korea, that doing per week up to 50 case, so I will learn this technique within, let's say, 1 month. While if I'm working in one center doing endoscopic spine surgery, 2 or 3 cases per week, so I will need at least 1 year to learn this technique. And also, if you have a backup surgeon, I started this technique, as Dr. Musa said, as alone. So I have to prepare every step. I have to arrange and put a plan B in my initial cases. But right now, my fellow, they face less difficulties when they are trained and to start, because I'm standing behind them. So any obstacles, I'll solve it. And again, every instruments and the material that they need to learn, it's available. So many factors that determine this, let's say, learning curve. Third question, that's what case to start with. We saw that's many cases from the expert to start with. For me, the ideal case to start for, let's say, for interlaminar is L5S1 posterolateral fresh disc. And we all know, and we demonstrated in the cadaver lab, the interlaminar space that's available for the, let's say, for the 5S1 compared with the 4-5. Again, you know, in my country, many patients, they send their pictures of MRI through, let's say, WhatsApp or Messenger, Facebook Messenger, which is unclear, holding like that and taking a picture and asking you about options. I never operate any case without preparing a CD, which is, again, it is unusual in Iraq. I know that in many centers it's a routine, but in Iraq it's not uneasy. So I request from any center of MRI provide me with a CD, because I have to study in details the cases and plan it, as Professor Horace says, through the CD. And also it's important to navigate and expect the intraoperative struggles that I could be faced through studying the MRI previously. And again, you have to select a thin with right choose, because, you know, I did many cases with the let's say pertorrhea or spinopelvic or sacral dysplasia cases. They presented with back pain and radiculopathy, and their back pain persists after surgery. And when I start to review, the surgery went well, nothing happened. I start to discover that some sort of abnormality, which could be the sign of, let's say, causing of their back pain. So I start to exclude such cases from doing, let's say, endoscopic spine surgery when complaining from significant back pain. How to deal with calcified disc? We all know that it's one of the limitation actually of the endoscopic spine surgery, especially in the uniportal, is dealing with calcified disc. But I don't think it's a limitation. So one of the methods that I like to do it, this is one of the paper that's let's say published by Ervind Carnegie. He's from India. He did amazing study, and I don't know how can he convince his patients like just to do lateral recess with foraminectomy without any discectomy, and they conclude with a very good result after that. So I think that you can do an indirect decompression in such cases of the calcified. Other option is to use the amazing let's say interlaminar scope from Maxmore, because it's offer you using the Kerrison up to size 5 with many tools, even the high-speed drill and the others, so you can deal with this calcification freely compared with the other small let's say scope. And another, as I didn't use it, but some guys they use it, what's called trophon, they use it to in order to burn and let's say put it in the calcified area, and they try to make it less. So how can you decrease the rate of the recurrence? When it's come to discuss about endoscopic spine surgery, they say that's all the recurrence rate, which is I'm totally disagree with them, because you know we are dealing with the endoscopic spine surgery is a target surgery. So the endoscopic, the tubular, the open is an access surgery. So what you will do through the endoscope with the disc is the same that you are doing with the tubular. So I think that's, from my initial cases, I faced some recurrence disc, but right now my rate of the recurrence is less, because you know I don't overdo. In the initial cases I remove much more of the annulus. Right now not. I'm doing in most cases just sequestrectomy, as you mentioned here. You know, see this is one of the last case I did it two weeks ago. I used this root retractor just to identify this sequestrated piece, and then by doing manipulations, and I extract the sequestrated pieces, and that's it. See, now it's totally free and ready to be removed. This is one of the benefit of the root retractor that's available for in Maxmore sets. So another, as I mentioned before, I'm using the lateral recess and foraminectomy because I discussed with Luiz Viali. He's from Brazil. He's one of the AO leader in the company in the world. He said that whenever you do a lateral recess with foraminectomy, the symptomatic recurrence is decreased. So I follow this instruction, and right now the recurrence rate in my cases is much more less. How can you have a good grip during surgery? You know, you try it, might be in the cadaver lab, that when you hold the scope for a long time, you will get fatigue, and you will not able even to control this grip. If you compare the interlaminar scope of Maxmore compared with the others they have long, let's say, scope, which is not uneasy to hold it, especially in the initial cases or when you have stenosis cases. So I personally feel much more comfortable with the short scope to handle and to hold it during the surgery compared with the others. When you can say it's enough, which is again a common question. Actually, let's say there is no clear answer toward this question, but I think that if you plan your cases in the advance by MRI, you will see that there is a sequestrated piece, so you just remove this sequestrated piece and that's it. If you have a calcified disc, so you will not expect to extract much more, let's say, pieces. And another point, that's some pulsation of the nerve root. Do you believe it or not? Personally, I don't believe it, especially in the interlaminar. Could be work in the transforaminal, but I think that you have to make a balance between what enough and what's too much, because too much that's mean recurrence rate and acceleration of the degenerative changes, and less that's mean, let's say, insufficient decompression and the other. So how to decrease a post-operative dysesthesia? I face it in my initial cases when I use the sleeve to rotate it. Right now I didn't use any sleeve actually, and I operate some cases in the initial series of my cases of a central disc. I stopped to do it interlaminary. I do it through transforaminal, and also I use the root retractor instead of the sleeve because it's diameter and give me more freedom toward the roots. And another important point, you have to be careful when you are dealing with the bleeding, because too much cauterization by RF might cause also this problem. How to control bleeding? First of all, you have to have an ideal mean pressure. In my cases, I put it around 60, and the pump it's around 35. When I face a bleeding, I increase it to 40 to 45, but never to above 50, although some literature supported you can use it up to 60, but I didn't use it. And again, when you face the bleeding, try to make the working channel close to the bleeding area in order to identify the bleeding, and also make cauterization if possible. Otherwise, you can use a wax if there is a bleeding or oozing from the bone. And these are some techniques that I use it. And again, you have to, let's say, to control with your anesthesia. That might be intraoperatively there was increasing in the mean pressure, and you have to control it. And I think that's last question. That's in my country, many open resistant surgeons, they try to ask, oh doctor, there is still remnant of the disc when you take an MRI. Actually, my answer, that's if I discuss with the patient, if you feel a good outcome post-operatively, so why you have to take an MRI? We don't have insurance company in Iraq that's asking about this MRI. So second question, that's to the open surgeon, that's, are you doing MRI for your open cases in order to compare the outcome or not? In my country, no one for open surgery doing MRI in their follow-up cases. And third point, that I already have recorded details of the surgery, so if any patient have suspicion about that, he can review their videos about it. Personally, I started to do an MRI for every cases post-operatively after 3 months, some cases after 6 months, in order to have an idea what I'm doing. But if you go to the let's say, these are one case that's after tubular, and see the amount of the muscle damage compared with this one after endoscopic. So there is no doubt about the outcome. But again, if you take the literature, many papers support that even the remnant of the material, disc material, doesn't correlate with the clinical outcome if the clinical outcome is good, and it doesn't reflect the success of the surgery. The clinical outcome is the prominent, and these are another paper that conclude that the residual disc material present in 24 of 33 cases, but this is not correlated with the clinical symptom. So I don't care about the MRI. So I will end my presentation with the 3 cases. I thought from my country that's it's a limitation of the endoscopic spine surgery. One of them is this case presented with foot drop. I heard many words from my colleague that they said that's one of the limitation is of endoscopic spine surgery is coda equina or foot drop. I don't know why. This is his X-ray and this is MRI, and I did endoscopically and remove it by, let's say, by interlaminar, and this is the piece. Second case, which is a revision case of mine, I did for her interlaminar, and then after 8 months she developed a recurrent disc in the same level, same site, and this is her recurrent disc. And again, I did imagine her weight is about 150, and I did for her interlaminar endoscopic, and see, dealing with the scar and soft tissue, it's not an easy, but still you can do an endoscopic spine surgery for revision cases. Even I had another case after tubular and one case after open. And I will end up with the third case about multiple level, which is I did for the last week. Again, two level of interlaminar, 4-5 and 5S1, which is total time of surgery was 40 minutes. So these are my cases and my experience, and thank you all for